We are now on the video record with tape number 1. Today's date is September 5th, 2017. The time is 4:53 p.m. Will the court reporter please surrender the witness?
Please raise your right hand. Do you swear or affirm the testimony you will give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Hi, Dr. Kozarski. My name is James Looper, and I represent Dr. Wang in his practice in this case. And it's my understanding that you have been retained by Mr. Kelly to provide some expert opinions against Dr. Wang. Is that correct?
Yes, sir.
All right. Will you state your full name for the record, please?
Alan Mark Kozarski.
All right. And you practice here in Atlanta, is that right?
Yes, sir.
And Clint, I'm going to say this before it went on the record, but I'm fine with ditching the locality rule if you are.
I am. Sure.
All right, we can put that on the record, and I won't go through all the locality
All right.
stuff, and we'll just have a stipulation that that's agreed to for all witnesses. Correct?
Yes, absolutely.
Doctor, I think you've got a copy of your CV
Yes, sir.
with you. If we could, we'll just make that the first exhibit to the deposition. And I don't need to go through everything on there. We'll save some time and skip over that. You've done this before, correct?
Yes, sir.
And you agree with me that physicians are not perfect in the practice of medicine, correct?
Yes, sir.
And you agree it's the practice of medicine as opposed to the perfection of medicine, correct?
Yes, sir.
And you agree that unexpected outcomes happen routinely in the absence of negligence?
Routinely? I'm not sure I would use the word routinely.
They do happen in the absence of negligence, correct?
They can happen in the absence of negligence.
And just because there is an unexpected outcome does not mean that there is a deviation from the standard of care, correct?
That is correct.
And corneal transplants are one of the risks of cataract surgery, correct?
The corneal decompensation is a known risk of cataract surgery. That is correct.
And with corneal decompensation, a transplant is frequently the method of treatment, correct?
With corneal decompensation, a transplant is the only method of treatment.
Okay. And you would agree with me that loss of the corneal endothelial cells is also a recognized risk of cataract surgery, correct?
Some degree of loss of endothelial cells does occur with every cataract surgery, correct?
And that's not an unexpected event in cataract surgery, correct?
A certain loss of endothelial cells during cataract surgery is a certainty. That will happen.
And with corneal decompensation, there is also a loss of endothelial cells in the cornea, correct?
Corneal decompensation, when the cornea can no longer remain clear and it becomes swollen, represents a devastating loss of most, or if almost all, of the corneal endothelium.
And I'll come back. Can you define the term standard of care for me, please?
That's not, standard of care is not really a medical term that we commonly use, but I think I've heard what a reasonably competent physician would do in the same circumstances in that situation, in a situation.
When were you first contacted in this case?
I don't remember.
Do you have emails or anything of that nature?
I may have emails with Mr. Kelly's firm.
Let me show you the notice of deposition, and I think you've got a copy of it in front of you as well. Is that correct?
Correct.
And we can just tag your copy as the next exhibit since you've got a copy of it.
And this is a marked up copy.
Okay, well, that'd be even better then. It's got your notes on it. Mm-hmm. And I'll take a look at what your notes are right quick. And it's the bold type notes on here that you're
Correct.
talking about. So we come down, number 1 is your CV, and we've talked about that. Number 2 says it's contained in your CV. Let me ask you this question: of your publications, abstracts, etc., are any of them dealing with use of the femto laser in cataract surgery?
I've given talks, concerning the Femto laser and its place in cataract surgery, and careful cataract surgery preventing corneal edema. I actually just looked through my curriculum vitae yesterday as I was getting ready to print it. So you can take a look through there, and I think you'll see stuff that's either closely relevant or distantly relevant in all the talks that I give. Cataract surgery is cataract surgery, and there are a lot of related talks if you look through that list.
And corneal edema is a very common consequence of cataract surgery, correct?
Temporary corneal edema is common. Permanent corneal edema after cataract surgery in someone without an underlying corneal issue is exceedingly uncommon.
But not impossible.
Nothing's impossible, but it's exceedingly uncommon.
And it happens in the absence of negligence.
It could conceivably happen. I'm trying to think of how could it just happen out of the blue. You would almost have to have some degree of underlying corneal deficiency in the absence of negligence. It's, this is a problem that we're going to talk about a lot during this. And just for a cornea to magically decompensate where everyone scratches their head and say, I have no idea why that happened, but I've seen that 100 times in my career or even 10 times in my career, that has not been my experience, nor the experience of anyone that I know.
Is there any literature that says that cannot happen?
You won't find anything in the medical literature which is an absolute. There's not 100%, there's not 0%, but that is pretty close to 0%. And having thought about this a lot recently, where I'm going on this is that we actually do cataract procedures in the absence of cataract these days. When someone comes in who's over the age of 50 and they wear Coke bottle glasses or they want to get rid of their glasses in some way, we do Femto or other cataract surgery on them. And one of the things that we don't worry about, okay, is their corneas going bad, because what we do normally is so gentle that anything that closely resembles a normal cornea is, that's not what we worry about. We worry about infection, okay, because we know that somewhere 1 out of 1,000 or 1 out of 2,000 people are going to get infected no matter how careful you are. But unexpected, permanent corneal swelling and decompensation is not one of the things that an experienced cataract surgeon worries about. Does it happen zero? Nothing zero, but I mean it's pretty darn close to zero.
Is there any literature that says that the only way that you can have permanent corneal edema post-cataract surgery is with a deviation from the standard of care?
I don't think you'll find any literature of that, but I think if you polled every cataract surgeon, they would come up and they would tell you exactly what I'm telling you. That's not one of the things that generally happens without a cause.
Do you know Dr. John Downing?
Do I know a Dr. John Downing? No, sir.
Do you know Dr. Keith Walter?
I know Dr. Keith Walter.
Have you reviewed his expert disclosure supporting Dr. Wang?
I think I've read everything that was available to me, including that.
So every ophthalmologic surgeon does not agree with you in that regard?
I think if we had an actual face-to-face discussion with these surgeons, we'd have a pretty good consensus.
Just telling you that you agree with me that I have 2 Rule 26 disclosures that you've seen that say that this can happen and does happen in the absence of negligence.
I think in what I'm telling you here, Dr. Walters would never, ever expect any of his patients with a moderate cataract to have unexpected corneal decompensation. I think that's one of the questions that's going to have to be asked to Dr. Walters. Has that ever happened to one of his patients where he's done a femto cataract procedure followed by? And I think you're probably going to come up, you'll have to ask him yourself, you're going to come up with a 0 on that.
It may be, but that doesn't necessarily mean that it can't happen.
Well, when we talk about cause and effect, all right, it's not that it can't happen, but it doesn't happen. It doesn't happen.
And with any unexpected outcome, it's not something that you're expecting to have happen in a case, is it?
I think you just... yeah.
You agree with me, right?
Yeah.
That's why we call it an unexpected outcome.
Right.
Before we get too far afield, you said you're giving some talks and presentations. If I give you a red pen, can you circle on your CV any articles, presentations, etc., that would be applicable to the issues in this case?
Relevant?
Relevant, applicable, whatever word
Okay.
you want to use.
Let's see, just going back here.
I'm sorry, thought that was on silent.
I didn't look that far back. I think I did give a presentation here on intracameral medication, Acuity in 2016, and the relevance of that, has to do with what you're putting inside the eye during cataract surgery and the safety as far as the endothelium is concerned.
Okay.
Do
Do you still have those materials?
I usually, once I give a talk like that that's unwritten, I get rid of them. You might find it in the Kiowa Eye meeting, keeps sort of archives that people can go to, open access.
Okay.
The other one that I saw, and I didn't go through my whole CV, Seeking Alpha, which would be regarding aberrometry and femto-assisted cataract surgery. We made a fairly early entry into laser cataract surgery. And the other one I don't see right here, and I don't want to use everyone's time, but I've given the talk a couple of times of how to perform endothelial-friendly cataract surgery in a cornea that has known endothelial compromise. And maybe I can find that for you here. But I saw that yesterday when I took a quick look. And those would be recent ones. I've given so many talks on, quality cataract surgery, and those would all have some relevance here. Corneal blunders and avoidable errors here would be one. I'll circle that. Premium implants for non-premium corneas would have some relevance to these talks. Anyway, I can go through the whole thing without wasting everybody's time, but there's a lot of stuff that has some relevance too.
All right. Maybe on a break we can have you circle the rest of them that you think are important, because that'll help me to study up on this. You said you may have emails. Did you bring those emails with you?
I did not.
Can you print those and provide those to Mr. Kelly? We'll make that the next exhibit. It'll be a late filed, whatever number.
And I will say that somehow on my Apple system, it's not really good for searching and indexing emails. And Clint, maybe your office has a better way of doing that.
I'll do that, Jim.
All right.
I got copies of it.
And you told me you don't remember when you were first contacted in this case,
That's
correct?
right.
What were you initially provided to review in this case?
I don't remember all the documents. The most important ones to me were those of Dr. Wang's office, and operating records.
All right, you mentioned that you told me earlier it was all provided to you via Dropbox.
I believe it was all done electronically.
So would everything in that Dropbox, would that have been provided to you initially, or were there other things added to the Dropbox at some point?
When I looked at the Dropbox yesterday, there were a couple of different dates, I think in 16 and 17, when things were added to the Dropbox.
So you can tell on the Dropbox when they were added?
Some smart person could probably tell when it's been added.
And you mentioned that we could link to that. Can the court reporter link to that so she can print everything out and make it an exhit to this deposition?
It's a shared file that we have, so whatever you want to
I
do.
don't have a problem with that, because it's linked into my office.
Well, I asked for everything to be printed and brought.
All I can do is tell you that the Dropbox file is something that I share with him, and there could be some work product in there that, you know, some linking with her is something I'm not comfortable with. I'd be glad to print off everything that's not work product.
Well, I mean,
But
we're
I don't-
going to need to take that up with the judge.
Let's do. I mean, I don't know.
Yeah.
I don't know what else to do.
My recollection is that it's all just files of depositions and everything. I don't think there's any work product in there.
Well, I don't know that you get work product once he gives it to you, so.
Okay.
But I mean, we'll just have to take that up with, I think it's Judge Brothers in this case, so that's fine. Just make sure you don't alter anything in that Dropbox, please.
Correct.
And I think you told me that you have not made any handwritten notes of your own, correct?
Yes, sir.
All right. And then, Clint, if you'll show him his Rule 26, and all I want you to do right now is confirm that it is yours. And we'll talk in more detail about it in just a minute. If you just take a quick read of that.
Mm-hmm.
While you're doing that, I think, Jim, he can print what I've sent him. I don't have a problem with him doing that. I just don't want to give a link to something that goes to my office. And so, if we get an agreement on that, I'll tell him to do that, and I don't want to pay for it either.
Well, he prints it out for me.
Okay,
So are you willing to do that, Doctor?
sure.
All right. We'll make that whatever number we're on.
Mm-hmm.
Lake file. His entire file.
All right.
Is that your...
Yes, sir.
Did you review this before it was served on March the 3rd of 2017?
I believe I did, yes, sir.
All right. And we'll come back and talk in more detail about that in just a minute.
Mm-hmm.
Does the Dropbox contain everything you've reviewed in this case?
I believe so.
When you were first contacted in this case, what were you told about the case?
I think I was, and again, I don't have any specific recollection of that. It's just that Dr. Wang operated on a woman whose cornea went bad in one eye, and there may be other issues. Would you be willing to take a look at it? Something like that, but I have no specific recollection of the conversation.
All right. You would agree with me that Dr. Wang did not know her cornea was going to go bad before he did this surgery, correct?
I will not agree with you.
You think Dr. Wang knew that her cornea
I
was...
don't know that he didn't know.
And on what do you believe he might have some knowledge that her cornea was going to go bad? What do you base that on?
Well, there is one possibility that her corneas were compromised to start with. And this is almost as logical as anything, that she had very, very compromised corneas to start with. And that could explain why one cornea went completely bad and the other one went to 700 cells. But that would presuppose that that specular microscopy was not hers.
So are you supposing that the pre-surgical microscopy was not hers?
Well, I'm supposed to think of every possibility, and that's a possibility.
Can you say that to a reasonable degree of medical certainty?
No, I'm saying that that's a possibility.
You agree that you definitely knew that she had had a cornea with permanent corneal edema and endothelial cell loss when you started reviewing this case, correct?
Well, I know that the second eye that was operated on got devastated corneally and developed corneal edema. We do know that. And we do know that the eye that was done first had, if you would assume that those were her speculars, had a drastic loss of endothelial cells.
She did fine on the first eye after surgery, correct?
She developed some edema in the first eye, but at week 1, Dr. Wang felt that she was stable enough to operate on the second eye.
And she's had no issues with the first eye, correct?
I don't know what she has subjectively or not subjectively or whatever, but what I do know is that I think on several occasions we've measured the endothelial density on that eye, which is sort of approaching a critical low level.
And it's actually increased from the time that Dr. Horn did that study until the time you did it, correct?
Well, within the error of measurement, we know that it's at a critically low level that subject to the usual attrition of cells during one's lifetime could drop below a level that could keep that cornea clear.
That has not happened at this time, has it?
No, that's a future consideration.
And you can't say to a reasonable degree of medical certainty that that will happen, can you?
If she lives long enough, her cornea will decompensate, but that may be living to 90, it may be living to 190. Nobody can tell you for sure, but corneas do deteriorate over time.
And that's all of us in this room, correct?
Correct, but all of us are starting at corneal densities in the mid-2000s and not at 700 or 800.
Unless you're correct and her spectroscopy was lower.
And if it was lower and that was not hers, then the wisdom of this procedure would be in question too. So that theory goes that way.
I understand. I'm just trying to figure out how you put your theories together.
Well, nobody can figure out exactly how this happened, okay? There are several leading possibilities that make some degree of medical sense, and whether it wasn't her specular and it was just sort of a stock photo or whatever he had around, or whether something happened devastating to the cornea during surgery in someone who had as good an endothelium as is depicted in those pictures. It's one of those two, but you know, it's up to us after the fact, and maybe Dr. Wang knows for sure, but it's up to us to figure out what we think could have happened.
Just kind of going through this list to make sure we've covered everything. Number 15 says a list of all malpractice suits that have ever been filed against you. You've listed one in the 1990s. Is that the only suit?
Yes, sir.
All right. Number 16 says you have not communicated with any other physician about this case, correct?
I have talked to several physicians, actually my cornea partners, without names or whatever, and just said, what would you think about this? And just doing a little reality checking, but nobody has any idea of Dr. Wang and the circumstances here. I wanted to make sure that I wasn't coming here totally off base and that my assumptions were incorrect and I was being stupid, and I just did a reality check there.
And then there's one where it says, number 18, all studies you, your current or former practicing hospital or clinic, you were affiliated with, or any university, etc., any medical society or board regarding any condition or diagnosis of Catherine Anderson, you have a not applicable to that. I thought you had done a medical exam of her.
Well, if that was worded into that and I missed that wording, I got lost in the legalese of that. Yes, I have done an exam on Ms. Anderson.
And while we're at it, we might as well just go ahead and make that an exhibit. I think that's a color copy of your notes. Is that correct?
Yes, sir.
All right, let's make that the next numbered exhibit, please. And then you've got some more notes in front of you that I think are responsive to some of the rest of this. You have a list of all your expert witness work.
Yes, sir.
Can we make that the next exhibit, please? And if you kind of want to just give her the exhibits and let her keep a stack of them, it might be easier. We mentioned this already about lawsuits. You ever had privileges suspended or
Yes, sir.
curtailed? Any criminal convictions?
Yes, sir.
How long has the Femto laser been used for cataract surgery?
I don't know the exact length of time. It has been around longer than it's actually been clinically used. I'm trying to think, even 10 years ago, I think one of our Honduran colleagues, Dr. Walls, who works with us in Honduras, actually took a black box version of that to Honduras to test it. And I think that was, well, maybe 10 years ago.
So it's been within the last 10 years?
I think popularity, we've had our Femto laser for 3 or 4 years, and I think it was coming into more common use maybe 5 years ago, but
Okay.
These days I totally lose track of time.
Gotcha. And that was roughly what I thought, somewhere in the 5-year range that it had been being used in a wider spectrum for cataract surgery.
Correct.
All right. How many Femto laser cataract surgeries do you do a year?
Probably a few hundred, maybe at most.
All right. We have that exhibit right there. In the year, say 2013, early 2014, how many Femto laser cataract surgeries were you doing?
2013, 14, I would have to actually look as to when we acquired our Femto laser, our Catalyst laser, and when we initially got the laser, I was doing a lot of Femto cataract surgeries, doing a lesser proportion now.
So you don't know if you were doing any of them in the year preceding February the 20th, 2014?
I don't remember if we've had our Femto for 3 years or 4 years. I think it's getting closer to 4 years.
Can you provide me some kind of documentation that would show
I
when
can
you
find
got
that out easily.
and then provide the documentation to
Yes,
back
sir.
that up? We'd make that documentation the next exhibit, please. And you read Dr. Wang's operative notes, correct?
Yes, sir.
Is there anything about the way he performed this procedure that you would do differently?
Again, it's a very cursory summary of exactly how it was done. I don't think it gives you every detail of, what happened during the surgeries. It just says that the laser was docked, the laser was performed, it made the appropriate incisions, and it, did what it does to soften the lens, but it really doesn't give any particular detail.
What about his deposition? Have you reviewed that?
At some point I did read it.
Does that provide you any additional information?
I don't recall any specific information where he gave any detail into, what happened in either eye.
You gave us your list of cases, right? Exhibit 6. I don't need it. I just want to make sure we have it. What percentage of your income comes from doing expert witness work?
Until last night, I didn't know that answer. I've always put off this question because I say it's not very much at all. And I've never really researched it, okay? In fact, when I was doing a case for your firm, your firm was very helpful to say, no, he doesn't really have to do that. You don't have to figure it out. It turns out in the last 6.5 years, which is how far my records go back, I've made about $132,000 doing expert stuff, which comes to about $20,000 a year, which is just slightly over 1% of my income.
And in certain states, that's correct. You don't have to do it, unfortunately or fortunately, depending on who's asking the question. Tennessee, you do now. So
it's a pain in the neck going through every little spreadsheet and figuring out what was and what wasn't. But you are the first person who has a comprehensive list in the last 6.5 years.
All right. What percentage of your work is for plaintiff versus defendant?
How would you separate the two?
Let's start. Well, let's just make it easy. Depositions.
No. What I'm saying is, if you look at those records, which I did for the first time, actually looking at it all at once, there are a lot of 1-hour reviews for plaintiffs that never went anywhere. Then, on the other hand, there's probably, if you measure it in terms of money, there's more money that's changed hands based on defendant cases. And it's actually your firm as an expert for your firm where I think the 2 largest checks were ever written. So it's pretty comparable in terms of number, the cases, but I think the money is more so on the defendant side.
All right. Let's try and mark it out this way. How many depositions do you give a year?
It varies a lot. They come, I would say in the last 6 months, I really hadn't done like a deposition, and then there was one that I did on Friday and one today. So I do a handful a year.
And of those, what's the percentage that you give for a plaintiff versus for a defendant?
Well, it's 50-50. I did one for the defendant on Friday, and I'm doing one for the plaintiff today.
All right. What about trial testimony? How often do you go to trial?
Thank God, very infrequently. Okay, very, very infrequently. Trials are maybe once a year, once every other year, if that much.
And of those, what's the percentage plaintiff versus defendant?
It seems like the defense cases have gone to trial more than the plaintiff's cases have.
All right. And then, I just saw this on here somewhere. It says that you are $650 per hour.
Yes,
Is that
sir.
correct? Is that across the board, depositions, trial, everything?
No.
Okay.
With trials where I have to take half days and days off, I basically just make an estimate of what the lost income from my office and Eye Consultants of Atlanta would be, and that's what I charge.
And do you have an estimate of what that might be?
I think the last time that I had to do that was for your firm down for a case where it was a case down in Savannah, and I had to take a whole day out of the office, multiplied it out, and it came to about $8,000.
All right. What about for depositions? Is it at $650 an hour?
Yes, sir.
And I just noticed that this was attached to the back of the notice. Looks like that's
That's an invoice.
All right. and we'll make that the next numbered exhibit. Is that the only invoice you have in this case?
For you, there'll be a supplemental one if it goes beyond an hour.
It probably will. I'm quick, but I'm not that quick, usually. Of course, my clock started ticking at 5, right? Or about 5 till 5, not when I first got here. So I don't know, we might get done in an hour. Have you presented any invoices for preparing your Rule 26, things of that nature in the past?
I think if you take a look through the emails that Mr. Kelly will give you, you'll see that there's some invoices in there. They should also be included in that comprehensive list that I gave you.
I'm sorry, you said which comprehensive list?
Yeah, you take a look at that. Towards the end, you'll
Oh,
probably...
okay. So is this the only case you have with Mr. Kelly?
No, sir.
How many? I see Doolin Kelly, I see Clint Kelly, I see Kelly Law Firm listed in here on several different files. How many times have you been an expert witness for the Kelly Law Firm?
Whatever it says in there.
Okay. When was the first time you became an expert witness for them? Do you know?
Whatever it says in there.
And is this the only way you would have invoices, is this time at the back of this?
Correct.
When you've done the examinations, did you only do one examination of Ms. Anderson?
I believe I only did one.
And was that paid by Mr. Kelly, or was that paid by Ms. Anderson's insurance, or how was that paid?
I believe it was paid by Miss Anderson's insurance.
You actually have a list of the cases that you've testified in, as opposed to set up in this invoice list?
No, that's the only record that I keep. Other than what you see behind you there are all the other records.
Which have that back so I don't get mixed up with stuff. I think the rule currently requires that the last 4 years of cases with jurisdictions be provided. And so I'll take a look at the rule. If it does, I would expect that that be provided.
If he knows, I don't know that he knows.
I don't know that the rule gives you that permission anymore, but we can talk about it. I'm just letting you know that should that be the rule, we'll make that the next numbered exhibit. It's possible that could be left blank. Is that a problem? All right. It says on here that you do not advertise your services as an expert. Is that correct?
That is correct.
Have you ever done that?
No, sir.
All right. Once you have that back. And Doctor, I didn't tell you this at the beginning, but if you ever need to take a break or anything, just let me know. Feel free.
I'm good so far, thank you.
Have you asked Mr. Kelly to provide you anything else in this case?
Not that I can recall.
Do you need anything else for your review?
Not that I know of now. Yes, sir.
And earlier when we were talking about how long the Femto laser had been around, it's a hot water heater, it rains back there. Do you agree with that there have not been any studies published on specifically on the Femto laser, cataract surgery, and adverse outcomes?
Do I agree that there had been no studies done or nothing published on adverse outcomes?
Right.
I haven't studied it comprehensively, but I know that there have been published reports on adverse outcomes.
Are there any studies that talk about what the risks of Femto laser are currently?
There are any number of studies, none that that I can recall specifically, but they all seem to indicate that the visual acuity that's obtained, the uncorrected visual acuity that's obtained with the Femto laser is a little bit better than doing manual cataract surgery, that in most studies the number of complications is greater with the Femto than it is with doing manual surgery. Surgical time is greater. There are any number of studies that say about the same thing. There are some studies that show that the endothelial cell loss is less when you use the Femto laser to soften the cataract.
Can you point me to those studies?
I could find you one, yes, sir.
Because I looked for a study, and what I found in several articles that they indicated was that significantly more research needs to be done on the Femto laser's risk to endothelial cell loss.
I seem to have recollection that there have been so many studies done because it's sort of a technology that's been looking for a purpose.
Mm-hmm.
And one of the purported things was that it will be better for people with compromised endothelium to use the Femto to pre-soften it, so you use less ultrasound. And I think there have been studies definitely where the ultrasound times have been less using the Femto laser. That part I'm sure of. I think maybe I can find you one that shows the actual endothelial cell survival was better. I'm not as sure of that.
If you can, we'll make that the next numbered exhibit. And if you can't, just let Mr. Kelly know, and we'll
Yes, sir.
notate the record as such. What journals do you consider to be reasonably reliable?
I don't know any unreliable journals.
Okay.
I read what crosses my desk. I think I get the American Journal of Ophthalmology. That comes through free for some membership. The ophthalmology, the journal comes through as part of a belonging here. You get the tabloids that come across. The American Academy of Ophthalmology has digested material that's pretty useful. Nothing in particular. Extraordinarily useful are the listservs and discussion groups because so much information is new that that is almost more helpful. Anything that's in journal print is a year or more old. Anything that's in a book is years and years old. And nearly all of us talk to each other on a nightly basis on all the discussion groups that are online as far as what current thinking is.
Are there any discussion groups that you blog on or write on?
I would say that CaraNet is one of them.
K-E-R-A?
-NET.
Okay. All right. Are there any, for lack of a better term, atlases or textbooks, things of that nature that would be applicable to this case that you would consider reliable?
No, sir.
And I can let you have Exhibit 5 back. Those are your records that you created. And they indicate that Mrs. Anderson was referred to you by Mr. Kelly, correct?
I don't know if it says here that it was she was referred by Mr. Kelly, correct?
All right. I don't want to go through every line of those notes, but is there anything in those notes that you consider significant for this case?
Well, it gives her uncorrected and best corrected visual acuity.
Okay, which is what?
The uncorrected visual acuity is 20/50 in the right eye, and J13.
What does J13 mean?
J13 is fairly large print that she's able to see without correction in her right eye. In her left eye, she has much better acuity at 20/20 and at J1, which is 20/20 acuity, both distance and near without correction.
So her left eye has perfect vision in it right now.
Her left eye has very good acuity. There's perfect vision. There's, we don't use that term.
Okay, so the lay term that I always hear with 20/20 is that's considered perfect vision, but
Well, there's always 20/15 vision, and she doesn't have 20/15 visions, but she has a very good level of visual acuity in the left eye.
no complaints on her visual acuity for the left eye.
We did not list any complaints in the left eye. She says there's glare at night. We didn't hone that down to which eye was giving her glare at night.
All right. And then in her right eye, I noticed some of the records from some of the providers she had seen before being referred to you indicated that she needed to have a YAG procedure, Y-A-G. Did you indicate that?
I did not make a specific comment about her needing a YAG capsulotomy.
And I believe it was Dr., I'm not sure how to pronounce his name, Groos, G-R-O-O-S, that was the first to make that indication that she was having some clouding of the posterior capsule behind the lens in her right eye, and that a YAG procedure would address and correct that.
No specific comment there for me.
All right. Do you agree, if she is having that clouding behind the lens in her right eye, that a YAG procedure will be what would correct that?
If any person who's had cataract surgery has a cloudy posterior capsule that's significantly affecting vision, they should have a YAG capsulotomy.
And that's a fairly common occurrence after cataract surgery, correct?
Yes, sir.
What was her corrected vision in her right eye?
Her currently corrected vision in the right eye with her glasses was 20/70.
I thought you said her uncorrected was 20/50.
Well, again, you'll see corrected and uncorrected all over the place here for near and for distance.
Okay.
And one of the reasons is when someone has imperfect vision, in between blinks, they'll be on one line in the eye chart or on, an adjacent line, either better or lower. As far as near vision acuity, she has a multifocal implant, and putting something into that sweet spot there may be difficult. So the measurements are all in the same basic neighborhood of vision, but they vary a little bit.
All right. Anything else in your notes that are significant for this case?
Just that I made the comment that she should be followed up and have a scan of her retina and a a scan of the optic nerve imaging to make sure that we're not missing any retina or optic nerve problems, because all the attention has been to the front of the eye. Just wanted to make sure we didn't miss any of that.
And would that have been caused by the cataract surgery?
Cataract, corneal transplant surgery, every surgery that happens can cause swelling in the back of the eye as well, and we become attention diverted to where we're doing our surgery and want to make sure that we don't lose track of the rest of the eye.
Has anybody done those scans?
I don't know the answer to that.
Have you done those scans?
I don't believe so. Unless it's right behind here. Let's take a look. Not that I see, no, sir.
And would you agree, I believe it was Dr. Gruz's statement, that if she had the YAG procedure, it would significantly improve her vision in her right eye?
Well, that will be, the result of that will be when you do the YAG laser and you see what the visual acuity is.
Is there any reason not to do that at this time?
If you were planning to do another surgery, if you were going to have another corneal transplant, it's better to keep the capsule intact.
Okay.
If no other surgery is contemplated, then I think you can go straight ahead to do the YAG capsulotomy.
And at this time, there's no indication to do another corneal transplant, is there?
Another thing that I've been thinking about with Ms. Anderson, she does have a multifocal implant. She does have a DSEC corneal transplant, which is the next to the most recent iteration of a corneal transplant. She might, at some point, if she just keeps butting up against 20/50 to 20/70 vision in the right eye, the DSEC transplant is not always a good combination with a multifocal implant. And the newest generation of corneal transplant called DMEC, these patients actually will function better with a complicated implant like the one that's in her transplant eye. So that would be something to be thought of in the future, depending on her level of complaint with the corneal transplant eye.
Her current endothelial cell count in the transplant eye is 1628, correct?
You'll have to direct me to where that is.
It was in Dr. Gruz's notes. I don't know if you did one in that eye or not. I can't remember. I know you did one in her other eye, so I assume you did one in that eye as well.
Well, they vary, but if he did that, the endothelial cell counts that we obtained are part of a confocal device, which is not the most accurate way of measuring endothelial cell counts. I would defer if he has a dedicated endothelial cell counter. I think Dr. Horn had one and Dr. Gruz. I would probably defer to them rather than, this is a little bit crude as far as measuring endothelial cell density is concerned.
So you don't have one of those in your office, the dedicated?
No.
Dr. Gruz also indicated in his notes that her right cornea was clear. Do you agree or
The
disagree
corneal
with that?
transplant is clear,
Okay.
correct. It's as clear as a DSEC corneal transplant can be.
Right. Is that a good thing or a bad? I'm assuming that's a good thing if it's clear.
We, in the old days, meaning 5 years ago or whatever, we used to think that was terrific, okay? And now that we have the newer generation of corneal transplant, we know that there's a fair amount of aberration and optical imperfection that's built into a DSEC transplant, which makes us all the more enthusiastic about the newest generation of corneal transplant, which is just one layer thick.
What was your recommendation for Mrs. Anderson?
I didn't have a specific a specific major recommendation for her. Just to be followed closely to assure the health of the transplant, monitoring eye pressure when you're on steroid eye drops, et cetera, et cetera.
All right, well, it might be a good time to take a bathroom break then.
Okay, all right. Please stand by. We're going off the video records. This is the end of tape number 1. The time is 5:48. Okay, we're back on the video record with tape number 2. The time is 5:58. Please continue.
Dr. Kozarski, I'm not sure if I got an answer to this or not, so I apologize if I'm asking the same question twice. But I was asking you, is there currently any contraindication to her having the YAG laser procedure in the right eye?
The only contraindication would be if another transplant was contemplated in the near future as her next surgery. You would want to do that before doing the YAG laser.
Has anybody contemplated another transplant that you're aware of?
I have.
Okay.
All right, and the reason why I think about that is because we have certain patients that have DSEC corneal transplants that never achieve the vision that they desire, and I have actually removed DSEC transplants to put on a DMEC transplant and gain several lines of vision by doing that. And that's a very, very hard decision to make, because you're making a bet on doing another major operation to improve vision a little bit. But until that decision is made and Mrs. Anderson would say, I'm happy with what I have, I don't want anyone to touch this eye again, I'm just going to live with sort of half the vision in that eye, at that point you would freely do the YAG laser.
Have any of our other providers recommended another cornea transplant?
I don't know that anyone else thinks along that line. I know that a lot of us that have done a lot of the newer kinds of corneal transplants have taken that strategy in helping people. I don't know if the doctors up in Nashville have thought about that or offered it to her.
If there is no corneal transplant contemplated in the near future, then there's no contraindication to doing the YAG, correct?
That is correct.
Do you agree that the surgical times for the 2 surgeries that Dr. Wang did would indicate a average time for this type of surgery?
Can you refresh my memory? What were the surgical times for each?
I don't remember them exactly. They were very short. Was there anything in the surgical times that stood out to you as being unusual?
I don't even remember what the surgical times were.
All right. Would you agree with me that if there were complications during the surgery, you expect to see a longer surgery?
Complications take longer time to fix, assuming that you're going to fix the complications while they're there. If you don't fix the complications, the short surgery can actually be worse than actually sitting there and fixing it.
I mean, typically if there's complications, it prolongs the surgical time even without fixing it at that time, correct?
I've seen some surgeons, bulldoze their way through complications in very short periods of time that they would have wished afterwards that they took their time and fixed it.
Is there anything in this case that Dr. Wang bulldozed his way through this?
There really is no detail here. We put on the Femto laser, we took out the cataract, we put in the implant lens, everything went perfect, honky-dory, and it's done. Isn't it the same exact operative note on both eyes? I think it is. I think they penciled in the phaco ultrasound time, but pretty much the narrative is it's just a word process narrative.
Do you agree that on Ms. Anderson's preoperative scans there was a variation in cell size and cell shape in her endothelial cells?
There's always a degree of cell size and cell shape that, that there's some quantitation associated with it, but the cell shape looked pretty much hexagonal and the number of cells looked pretty normal to me.
So you do not agree that there was an abnormality in the shape and size of the cells?
This argument has happened, and I always say that maybe I'm crazy and I look at things differently than anyone else does, and maybe I'm wrong, and this was just a cornea that was ready to go bad, and poor Dr. Wang just sort of took this, did the best that he could with this terrible cornea, and that's why they went bad. Like I said earlier, without any kind of identifying information, I took the specular microscopy and I presented it and showed the picture to the head of our local eye bank, the one that succeeded me as the head of the Georgia Eye Bank, who I would say is one of the top 5 cornea people in the entire United States. And I asked him the question the hard way, and I said, Doctor, here's a specular. This is for a corneal donor. Would you allow this corneal donor to go out the door for a transplant on someone else? And that's a pretty high bar. And the doctor said, no issue at all. This would go out the door as a donor. So whatever arguments are going to be made that this was not the perfect cornea, that this was compromised and it was just a corneal disaster waiting to happen, I think there's a pretty strong argument against that.
Do you do corneal transplants?
Yes, sir.
All eye surgeries involve some trauma to the cornea, correct?
No, sir. There are eye surgeries that are far away from the cornea, but if you want to...
I meant to say all cataract surgeries.
I want to make sure that I don't say something stupid.
No, you're
okay?
correct. I meant to say cataract. I said eye and I meant cataract. So you're absolutely right.
Cataract surgery, you're always going to lose a few cells.
Has there been any instability in the left endothelial cell count in Mrs. Anderson?
Let me take a look at my sheet here. To my knowledge, there has not been yet any recorded instability in the left endothelial cell count.
Do you agree that, well, first let me back up. The DSAC, D-S-A-E-K, when we were talking about that earlier, that's all caps, it's an acronym. And will you tell me what that acronym stands for, Doctor?
Decimase stripping automated endothelial keratoplasty.
And that's essentially a transplant of the inner layer of the cornea to replace the bad endothelial cells with healthy endothelial cells, correct?
Correct. It's a layer which includes part of the corneal substance, part of the corneal stroma, plus decimase membrane, which is the carrier for the endothelial cells. So that may be 100 to 150 microns thick, and it's sort of done as an onlay to the back of the cornea.
And then you agree that the partial cornea graft, the DSAC, has done well in her right eye and her cornea is clear at this time, correct?
The DSAC is functioning, which has taken away the corneal swelling in the operated eye.
You would agree with me that since she had the cataract surgery, or since she had the DSAC, that her endothelial cell count in that eye has improved and her vision has been improving over that time in that eye.
The DSEC gave her an improvement in vision compared to when her cornea was completely swollen, yes.
What was her vision before having cataract surgery?
I believe, without going through all the charts, was basically maybe the top letter or so on the eye chart versus counting fingers. It was extremely poor.
So her vision is currently better than it was before she had cataract surgery.
The vision is improved after the DSEC transplant, yes.
And that's in both eyes, correct?
Well, she's only had a transplant in one eye.
I'm sorry, I meant to say her vision has improved in both eyes after the cataract surgery.
Well, her vision decreased in her second eye, right? She started off, I believe, with 20/30 or 20/40 correctable vision with her cataract. And her vision eventually got better than that in the eye that didn't need the transplant. It really hasn't returned to her preoperative level even after the corneal transplant.
Are you all talking about the same thing?
I don't think so. 'Cause
I think, Alan, I think what he's talking about, and correct me wrong, Jim, is the difference before she had Dr. Wang's surgery compared to where she is now. And it seems like you're talking about after the transplant surgery.
So let me rephrase it. Yeah, that's what I'm
okay,
trying to
I think
ask.
it's
You're
more
on.
right.
Yeah.
I'm sorry if I misunderstood.
Yeah, so her pre-cataract surgery, before Dr. Wang did surgery, her vision then, and let's go with the left eye first, is better today than it was before she had cataract surgery in her left eye.
All right, I don't want to mix up left and right here. The left eye is the eye that did not need a transplant, and her visual acuity is better now than before her cataract surgery.
And then going to her right eye, the one that did need a transplant,
Correct.
that vision is also better today than it was before cataract surgery.
No.
Okay, explain that to me.
We're talking about best correctable visual acuity,
Okay,
okay? She was 20/30 to 20/40 before her cataract surgery.
okay,
She no longer, even with her clear corneal transplant, she doesn't reach that level of visual acuity. So you can't really say in terms of eye chart visual acuity, she's worse than she was before cataract surgery in the eye that required the corneal transplant.
okay. It's my understanding from Dr. Gross's records, or Gru's, however you say it, Gru's records, that she's at 20/50 in the right eye, the eye that needed the transplant.
That's her, if Dr. Grew says that's her best correctable level of visual acuity, then you have to take a look, what was the best correctable level of visual acuity before Dr. Wang's cataract surgery? And I believe it was 20/30 to 20/40 in both eyes prior to the surgery.
Okay, so the right eye is somewhat worse.
And the left eye is better.
Okay, and the left eye can be corrected to 20/20.
Correct.
All right. Do you agree that in the eye that's had the transplant that there's a better than average chance that the vision will continue to improve in that eye?
I think that the visual acuity will remain fairly stable. The YAG laser could possibly make it better. The time frame could, over a couple of years, it could get a little bit better, or it could just stall at where it is because of the complicated optics of a multifocal lens and all of the optical aberration and stuff that's induced by a DSEC corneal transplant. We see many eyes like hers that stop at the 20/40 and 20/50 level, and that being their best ever level of visual acuity.
And do you agree that small amounts of scar tissue cause more blur with multifocal intraocular lenses than with monofocal ones?
Yes, sir. The cornea, you need a nearly perfect cornea, actually pretty much a perfect cornea, in order to have good and tolerable vision with a multifocal lens.
Do you agree that swelling of the cornea following cataract surgery is rare, but is one of the more common post-operative complications?
No, sir, I don't think I agree with that. In the absence of a known corneal abnormality, permanent swelling of the cornea is very, very, very uncommon. The more common complications that occur by far are swelling of the back of the eye, a clerical error as far as implant selection is concerned. If you take a look at what happens litigation-wise after cataract surgery, unintended corneal swelling is, I mean, incredibly small on the list. Infection is there, improper implant is there, other things, retinal detachment, retinal tears and detachment are there, but totally surprising and flabbergasting corneal decompensation in what you thought was a normal cornea is as close to never as you can imagine. Not zero, but as close to never as you can imagine.
It's not zero, though, correct?
I'm never gonna give you a zero.
All right. And you agree that modern partial corneal transplants have allowed about 90% of patients with post-operative corneal edema to recover good vision?
No, sir, I would say the number is higher than 90%.
What is, and I'm hoping I pronounce this right, Fuchs Dystrophy? Am I saying that correctly?
Fuchs corneal dystrophy is an inheritable condition that's characterized by the appearance of the back of the cornea sort of having a pigskin texture to it, and as time goes on the cornea gets thickened and swollen, and it is one of the most common reasons why people require corneal transplants.
Can it occur without gutta, or guttata rather?
You know, it's basically, you could call it non-Fuchs, Fuchs dystrophy, non-gut, you know, without the gutta, or which is really the pigskin kind of quality to it, and just have a corneal deficiency. It can happen. It can happen. It's very uncommon. I'm not sure I would call it Fuchs dystrophy. I would call it maybe a non-Fuchs corneal dystrophy.
And that's something that you would not be able to detect, correct?
Well, if you're doing a specular, you know, if you're really on your A game, if you're on your A game as a clinician and you're doing your scan across the cornea, there is a way of getting a pretty good specular picture even without a specular microscope. You can do that at the slit lamp, and a lot of us will do it when we're sort of on our A game and trying to assess somebody's cornea.
It can go undetected without a deviation from the standard of care, correct?
You could have a low endothelial cell count in a non-guttate, non-Fuchs cornea and go undetected outside the standard of, and that would be within the standard of care. It wouldn't be a breach. Or you're going through that. Maybe I just ought to complete that statement. I'm afraid that one's going to come back to me out of context. If we had a non-guttate situation like this, this was one of the scenarios that I thought of. If you didn't have a specular picture, if you didn't have that specular picture, and Dr. Wang was not on his Super A game and he missed the fact that she had a very low endothelial cell count, let's say 900, in each eye. And if he just missed that and there was no specular, I mean, you can see how he could have driven on his good operation 900, he could have driven to 700, and on a rougher operation he could have driven 900 down to not enough to keep the cornea clear. But that theory goes away because of the specular. So you can't really think about non-guttate Fuchs if you have that specular microscopy and you believe that that belonged to Mrs. Anderson.
I didn't think that the actual count was what was relevant in the Fuchs dystrophy.
The count is very important, and the Fuchs dystrophies that are doing bad, that you worry about them, are 1,500, 1,200, 900, and there are big gaps in there where the little lumpy stuff is in Fuchs. It doesn't look like that.
But you can have a Fuchs dystrophy even with a count of 3,000, correct?
You can early on, but that's not what a specular microscopy looks like of a cornea that's going to go bad in Fuchs dystrophy. Let me expand on it one because I'm not sure I'm being clear. We have people with Fuchs dystrophy that have that have obvious Fuchs dystrophy, and they have cell counts of 1,000 or less, and we'll do very careful cataract surgery under those corneas, and we don't make them go bad. We can get away with it. It's the same thing as having someone who had a corneal transplant 35 years ago, and their endothelial cell count is 700, and we do cataract surgery under corneal transplants with cell densities of 700, and we're careful and we get away with it. Those corneas don't go bad. That's why I'm so taken aback by having cell counts of 2,400 where you lost 2/3 or 3/4 of the cells, or made all the cells go bad in the eye that needed a transplant. That's why it's so hard for me to put this together. If this happened, anything, with any kind of degree of, remotely happening occurrence, I'd worry about every person that I operate on. Okay? That's not one of the things that keeps me awake at night. I tried to think through my whole career of people where I caused the need for a corneal transplant. Okay? That's a bad thing. You remember it. If you had someone with an otherwise normal cornea, you go and do cataract surgery on them, and they need a corneal transplant. And, I can't remember anyone, I have no recollection of anyone where I didn't expect, where I didn't expect the corneas to go bad and stay bad.
Okay. Just because you caused a corneal transplant does not mean you deviated from the standard of care, correct?
But with modern cataract surgery and the way that modern cataract surgeons routinely perform cataract surgery, I'm looking for a 5 to 10% endothelial cell loss. Okay, that's what we're looking at. That's what we think about. That's what we talk about with each other. And to have 3/4 of the cornea destroyed or 100% destroyed, I mean, if that happened with any occurrence, we would wait until cataracts got really bad before we take the chance of causing the need for a corneal transplant. It just doesn't fit in to what our observations are over decades of practice.
If that could not happen, why are there studies discussing significant endothelial cell loss after cataract surgery?
What are you calling significant endothelial cell loss?
I've seen numbers ranging to 90% to 80%.
I want to see that study. I want to see where routine cataract surgery, somebody's routine cataract surgery causes a 90% loss of endothelium. Okay? And I want to see if that is a credible study by someone that makes sense. If we really thought that that could happen, we wouldn't practice eye surgery the way that we practice it.
Alan, you may want to tell him, because I don't know if we're talking about the same thing, but the study that Dr. Wang sent us, that may be what he's talking about.
Right, and that really, I think we had asked Dr. Wang to show us a credible study from a credible author and source where otherwise well-performed modern cataract surgery could routinely have have 50, 75, 90% endothelial cell loss, and he sent a study that really didn't even try to answer that question, and that question is still out there for Dr. Wang. We want to see if you can show me that routinely every day, with some degree of frequency, there are eyes that lose 90% of their endothelium with just normal cataract surgery, much less modern operating room surgery, much less softening the nucleus with a femto laser, and they're getting 90% endothelial cell loss. Man, that is a revolutionary thought. That would make most of us just stay in our office and not want to go to the operating room.
Risks happen in all surgeries, correct?
There is risk in everything, but it's a measurable risk. You know what risk you're taking. That would be a game changer. Okay, that would be a game changer. I'm not going to tell my next door neighbor that she can have a clear lens extraction to get rid of her glasses if I thought that there was any kind of reasonable chance that I was going to cause her the need for a corneal transplant. I wouldn't do it. And trust me, I do clear lens removals on my next door neighbors.
And I'm talking about what the standard of care is right now.
I mean, I'm no great cataract surgeon. My fellows that are coming out of training are as good as I am. All right, my cornea partners are as good as I am, and I'm telling you, this has been my experience as just an experienced average cataract surgeon.
All right.
I would hold out my experience as standard. I'm no surgical Superman. The other thing I'll say to amplify on this, because I'm always afraid I'm going to forget to tell you everything that I want to tell you, is that we go down to Central America, and you should see how we operate on eyes, okay? With eyes that have known abnormal corneas, all right, because they have Fuchs dystrophy and everything down there. We don't use phaco. We open the eyes to a big incision, and we basically make the hard nucleus. We're talking a very mature, rock hard nucleus come out of the incision as one piece and squeeze through like you would deliver a large baby. And guess what? They don't have that degree of endothelial cell loss. I can't remember any permanent corneal edema that we've caused in doing 25 years of missionary surgery in Honduras using very, very primitive techniques and not having the benefit of endothelial cell counts. We've caused infections. We've had other problems, but we don't cause corneal edema. Basically because we have all of these protective substances that are inside, that we use inside the eye to protect it.
And if you need to look at your Rule 26, Mr. Kelly's got it. But as I understand it, you're going to opine that Dr. Wang deviated from the standard of care in performing, or in the way he performed this surgery on the eye that needed the transplant, and this caused an injury to Mrs. Anderson. Is this correct?
No.
Okay.
I'm going to say that I keep it in my own words.
All right.
Okay? I'd keep it in my own words. And I would say something with all reasonable certainty, something happened here that was, you know, that caused her to need a corneal transplant in one eye and to lose most of her endothelial cells in the other. And whether it was starting from a different level of endothelium from what is depicted in the images that Dr. Wang has, or something happened in the operating room that we don't know exactly what it is, but it did happen. And, you know, being rough with the cornea is a possibility. The other possibilities include something being put inside the eye that was toxic to the endothelium. And of the things that you could do to get a dramatic decrease in corneal endothelium, that's probably even easier to do as a cause of destroying endothelium as anything else. We have a word process operative note that says that, you know, some sort of lidocaine was placed inside the eye, you know, during the time of surgery. What was really placed inside the eye? If I had to place bets on what could really cause that much endothelium to be lost, maybe there was something of the wrong you know, pH, you know, the wrong acidity, or, you know, that was not compatible to inside the eye, that would, you know, there was a more concentrated version of it that went into one eye than the other. What was being done innovative? You know, I've seen cases of eyes destroyed when I used to run the residency program at Grady, where they would take what should have been a balanced saline solution, and instead one of the antibiotic solutions got injected inside the eye. There are very finite limits of what you can put into the anterior chamber of the eye that the cornea will tolerate. And one of the most plausible scenarios is something got inside these eyes that the endothelium just didn't like.
Can you say to a reasonable degree of medical certainty that Dr. Wang deviated from the standard of care in causing this?
I'm gonna leave that to you lawyers to decide on what is a deviation, but I'm saying I can't think of a plausible reason why she ended up, Mrs. Anderson ended up with the corneas that she has under normal circumstances. And with all the information we have, I can't imagine why she is where she is.
Could it have been an allergic reaction to the
Not
solution?
aware of any allergic reactions that occur inside the eye. The eye doesn't really have internal allergic reactions.
Could it have been a contaminated solution that Dr. Wang was not aware of?
Could have been. It could have been. You know, they have certain patterns that happens, but that's one of the more plausible things that I would think of, that something went inside that eye. But then again, you know, if it were my ambulatory surgery center, you know, where I'm a partial owner, you know, with my partners and I'm the surgeon, I'm responsible, like it or not, for anything that happens on my watch.
That's not the law in Tennessee, and Dr. Wang is not the owner of this surgery center.
Well, I consider myself the one who runs everything, and therefore if it happens when I'm the surgeon, it's my responsibility.
You're not opining as to the law in Tennessee in that regard, are you?
I'm doing everything that I can not to make legal opinions. I'm trying to give you medical opinions.
And so if Dr. Wang was unaware of a contaminated substance, which you said is the most likely cause of this, then that would not be a deviation from the standard of care on Dr. Wang's part.
I'm going to say that it's up to the surgeon to know what's there. If there is a devious enough saboteur in the operating room that is going to get past Dr. Wang to make something happen, you can argue all day long whether a saboteur could make this happen. But a doctor, the surgeon, should be aware of everything that's in the operating room. He should take a look at this lens. He should take a look at what is being told to him is unpreserved lidocaine. He should be aware of what's being put in the balanced saline bottle, the irrigating bottle that has a certain kind of epinephrine but not another kind of epinephrine, et cetera, et cetera. That's my responsibility.
Do you draw the medicine up?
I will watch them every so often. I'm one of the, I will sample their behavior and do my own internal audits on what's going on. And I would hope that my patients would want me to do that.
Standard of care does not require you to watch another professional draw up the medicine, does it?
I don't know what standard of care is. I'll tell you what I think is a reasonable thing for a doctor to do.
And
standard of care doesn't require that no other chart comes in the room at the same time, that my patient is there, nobody else's implants. There are a lot of things that I don't know what is the standard, but I would consider it medically reasonable to do.
the question is what's medically unreasonable? And it's not medically unreasonable to have a nurse draw up your medicine, is it?
You should know where it's coming from.
Do you manufacture the medicines?
No, I don't manufacture the medicine.
And you can't possibly be there to know whether a contaminant got in that medicine when it was manufactured, can you?
But don't they have other patterns?
I don't.
If there's a contaminant, shouldn't there be other cases and everything?
Did you ask for that? Did you ask for any data in that regard?
I'm not aware of any other cases that are happening. That would not be a bad idea to ask that, though, to see if there's a whole flurry of Miss Andersons out there.
And so my question back to you is, the doctor can't possibly be expected to know whether there was a contaminant in the medicine that got used that day, can he?
The doctor should at least try to know everything that's going on around him.
So if it's manufactured improperly, he has to know that?
The answer is that if the manufacturer comes in with something that was improper and it's a dangerous product, you're going to find out soon enough. And then, again, there's going to be manufacturer's liability. But I don't think that's a play here.
Tell me how Dr. Wang deviated from the standard of care.
Either mechanically or chemically, something happened inside these eyes with the 2,400 cells to make them decrease.
And the most likely cause, in your opinion, is something chemically happened, correct?
I would think so.
Right.
I would think so, but I can't tell you that. I've never seen him do a phaco emulsification operation. I don't know if he's a gentle surgeon. I don't know if he's a rough surgeon. But I can tell you that what happened to the cells in this case are so far out of every other surgeon's experience.
You know what's happened to every other surgeon, sir?
I talk to a lot of surgeons.
So you can say to a lot of them, but not to every surgeon, right, sir?
To every surgeon I've spoken to, and that would be dozens and dozens.
Right. Doctor, have we covered all of your opinions in this case?
There are none that I can think of right now. If I can think of others that I've not mentioned, then I can send them to you.
All right. Well, this is my chance to ask you questions, so if you can't think of anything, I'll take it that we've covered everything. I'll give you a minute to think about it and make sure.
Well, let's give him an opportunity to read his report. I think that's the fair thing to do.
Well, I thought he'd done that at the beginning, so I'm sorry.
To reread it and make
That's
sure
fine.
everything's covered. He may have, I don't know.
I'll let you turn that back on.
Sure.
Okay.
Have we covered everything, Doctor?
Yes, sir.
And I have no further questions. Thank you, sir.
That's it.
What would the witness like to do about reading and signing?
I would like him to read and sign, if you don't mind, Doctor.
Okay.
A lot of words in there too that,
I'm sure she got them all right.
All right. Please stand by. We're going off the video records. The end of tape number 2. The time is 6:38.